My name is Matt Dobson, and I'm your host from Ventripoint Diagnostics. Today, our session is titled Challenges in CHD Precision Serial Monitoring of the RV. We are focused on critical care gap in congenital care, how to obtain cardiac MRI level precision for the RV volumes and injection fractions at the point of care without the limitations and risks associated with traditional cardiac MRI. Today we have three presenters with us to walk through the strategy, the technology, and the clinical evidence. First, we'll hear today from Joe Hostetter. Joe is our business director for our CHD program here at Ventripoint Diagnostics. Joe oversees the strategic direction of our work within the congenital heart disease community and works closely with our clinical teams to integrate precision imaging into their standard workflows. He'll be providing an overview of why we focused on this diagnostics gap and how VMS Plus is solving the MRI bottleneck. Next up, we'll hear from Jim Grabber. Jim is our Senior Clinical Applications Manager. He leads our customer training and support team and provides vital clinical insight into our product development team. Jim brings over 20 years of experience in echocardiography, notably as the former director of the Toronto General Hospital Echo Lab. He is going to ground us in the technology, showing us exactly how our flagship product, VMS, turns standard 2D echoes into cardiac MRI accurate 3D models. And finally today, we are honoured to have Dr. Greg Skinner. Dr. Skinner is consultant paediatric cardiologist and clinical lead at the East Midland Congenital Heart Centre in the UK. He'll be sharing his first-hand clinical experience and case studies, showing exactly how he uses VMS serially to monitor patients and inform critical care decisions like the timing of a PVR. So here's our agenda for the next 45 minutes. We're going to start with Joe, who will give us the CHD landscape and defining the MRI bottleneck here in North America. Then next up we'll have Jim, and Jim will work us through the VMS workflow from scanning through to the 3D reconstruction. And then we'll have the clinical case study from Dr. Greg Skinner. He'll present his longitudinal data from his own practice and focusing on the serial monitoring of his pediatric patients. And then finally at the end we'll have 10 minutes of interactive discussions. Just a quick reminder today that you'll receive the recording tomorrow along with a link and the white paper to your inbox tomorrow. Please use the Q&A box for any questions you have tonight. And with that, I'll hand the floor over to Joe. Joe, please get us started.
Thank you so much, Matt. Mine is more just an introduction of myself and the role that we are concentrating here at Ventripoint. A lot of the members of our audience are quite aware of the congenital heart defects and the need that we have. And according to the CDC in 2025, we had over 2 million people that are living with congenital heart defects that actually requires monitoring. 55% of these are mild, but as you can see with the data that's up here, the remaining 45% are more complex, and these require very accurate RV functional analysis. Since 1993, we have a lot of success, and we are now getting survival rates that are approaching 65% that are now going to 90%. This is creating some challenges, though. It's actually increasing healthcare costs in US dollars. That's $9.4 billion in healthcare costs that are now related to monitoring. And then we also have some challenges with reproducibility. Suboptimal cardiac windows for traditional 2D echocardiography continues to be a challenge, so this makes cardiac MRI still the gold standard for a lot of these complex monitoring situations. That can be a challenge in certain rural communities where patients have to travel long distances. It can be a challenge for scheduling. And when we're still in an inpatient situation, this can create challenges on discharge in a timely manner. So we've seen an increase of about tenfold in the past 10 years to cardiac MRI. Next slide, please. So our vision at Ventripoint with developing the VMS Plus solution is to try to bridge this gap between a readily available 2D echo and the analytics and reproducibility that you have with a cardiac MRI. So VMS is designed to create an accurate 3D model of the heart from a standard 2D echocardiogram, I'm sorry. And this is going to allow us to obtain the cardiac metrics on all four chambers of the heart within minutes. We're going to be talking today mostly about the right ventricle, but this does increase accuracy around the area. And better yet, we don't need perfect images because of the AI knowledge base and the reconstruction that we're able to do on these. So this reconstruction allows us to produce a 3D model of the heart, and this enables that accurate cardiac volumes, ejection fractions in a location that can help serve these underserved communities and patients where cardiac MRI may be contraindicated. Next slide. So as Matt mentioned, today's presentation is going to focus on specific applications for congenital heart defects. We can actually do all chambers of the heart. And with that, I'm going to, for the actual operation and everything, hand this over to Jim Graba. As Matt mentioned, he's part of our development and implementation team, and he can go through the analytics and how we actually accomplish this. Thank you very much.
Thanks, Joe. So let's get started. I'm going to talk about today our flagship product, the VMS 4.0. So what is Ventripoint Diagnostics? We're focused on cardiovascular disease. We were born out of the right heart, but what we do is we provide accurate volumes and, of course, subsequent ejection fractions for all four chambers. We're headquartered in Toronto. We're listed on the TSX, and we're initially a spin out from the University of Washington, and our IP is licensed still back from them. What's our value proposition? We are an affordable product, and we bring accurate diagnostic MRI equivalent volumes and assessment to the echo lab. And it's all from the convenience of an echocardiogram that already uses high spatial and temporal resolution. And we know that the echo lab is more accessible than an MRR. And we are FDA and Health Canada and EU approved. It was initially developed out of the University of Washington to answer the question of the right heart. The right heart has a complex shape. There are challenges with visualizing all parts of the RV. And then there are those challenges with placing pediatric patients inside the MRI. Subsequently, once we mastered the RV, we spun that out to the other four chambers, or the three chambers. So you're all familiar with the shapes and sizes of the pediatric or the congenital heart, the right heart. So wherever a functional analysis is required, this is where we can provide that level of quantitative measurements as opposed to purely a qualitative. We've been used, or our device is used in the research capacity and in the clinical capacity, and here's some of the peer-reviewed articles. So what is our device? This is our device. It's a medical grade touchscreen console that has everything self-contained within. And that self-contained is our application that contains our knowledge-based reconstruction algorithms to generate the 3D volumes. We are echo machine agnostic, and this small footprint of our device can let it travel within the hospital, so down to the ICU if required, or things like that. The other part or key components of our system is their transducer sensor and the patient sensor. And these sensors help us generate a position information of the image or the cine that's being acquired. This is an example of our 3D printed sleeve that goes on top of this, in this case, the GE M5SC transducer. It fits inside, and then we slide our transducer sensor right on top. And here's a typical setup of an imaging suite or an imaging room. The echo machine and the sonographer and the patient all live in the same place. We're not asking for anything different. And right beside the sonographer would be our console. We guide the user through. We ask them to put the sleeve on, put the transducer sensor on, apply the patient sensor onto the patient, and we ask you to set up the communication to start imaging. Here's the typical setup. This is all standard fare that you use every day. We set up the communication between the two sensors to start our imaging session. And we go about doing an echocardiogram that's as per usual that you do daily. So we acquire and then we save that cine. And at the same time, we just reach over and we touch our screen and acquire the position information. So the echo machine acquires the image information, and our technology acquires the position information of that cine. We guide the user through the workflow. We have our checklist here that the sonographers will be using to understand what's going on with respect to each chamber. We've refined our technology and enhanced it to make sure that it fits within inside the Echo Lab. We fit inside the hospital or your institution the same way as any other device. So we are wired into your hospital network. The Echo machine is already on your network, and we have a standalone workstation version for analysis. We are fully DICOM integrated. So there was some old technology before where we acquired images in a different format, and everything lives on our console or lives within our workstation. Nothing is sent out to a cloud for analysis and come back in. Everything stays contained within the hospital. We've taken advantage of the AI and AI technology. Typically, after an imaging session is completed, you're left with the cines to be analyzed. We can see the peristernal long axis, the RV inflow, RV outflow, the short axis at the level of the aortic valve. And so what we do is the user finds end diastole. We use our AI to apply the tags. We find end systole. We use our AI to find the end systolic tags. And they're still always editable because you guys are the experts. The AI is pretty smart, but you guys are the clinicians. And for this example, for the right heart, we have certain anatomic tags that we place. And then once all the tagging is done across the imaging set, we use our proprietary knowledge-based reconstruction algorithm, and we generate a three-dimensional volume of the RV. And in this particular instance, we show the RV. We can show end diastole and end systole. We've built in features to provide a better understanding and representation of what that volume looks like within the 2D world, which is where we regularly scan, but we don't quite appreciate how that 3D volume fits inside the 2D world. But here we give you that opportunity. So we understand that you want some feedback. The 2D image that you can see on the screen is the real world. Once the analysis has gone through our KBR and our data set, we provide a confirmatory aspect of how well is our technology working. And here you can see that there's good conformity to the endocardial borders with respect to how our KBR interprets that. And we can see that in the short axis and in the four chamber. This is representing all the scan planes that are required for obtaining an RV volume. In this particular instance, we can see the RV outflow. We can see the short axis at the level of the aortic valve. We can see the parasternal views. We can see the short axis views over here. And of course, once all this analysis is done, we've got a full report package. And this is a customizable report package that can go into your EMR or into your echo reporting system, or we can certainly work with you and extract just the key components that are required that you desire for populating your echo report. Now I'm going to hand it off to Greg Skinner, and he's going to explain to you how he's using this in his clinical environment.
Okay, thank you very much, Jim and Joe, and thank you very much, Matt, for inviting me. Thanks to Ventripoint for inviting me to share my experience. My name's Greg Skinner. I'm a paediatric cardiologist working in Leicester in the UK at the East Midlands Congenital Heart Centre. I have been using the Ventripoint system since way back around 11 years ago. So hopefully I've been quite used to using it and can just share a little bit of that experience with everyone on the call today. Just for a direct declaration of interest, I do work as a paid independent advisor to Ventripoint to help them develop their system for the needs of clinicians. I'm going to just start by outlining a bit about what the clinical problem is. I'll go through again just a little bit about what Ventripoint is, how we use it in actual clinical practice, how it applies to congenital heart disease, and finally, I'm going to take you through a couple of case studies to demonstrate how useful it is over a longer period of time. So just really the problem. We know that assessing cardiac chamber size and function really is quite fundamental to managing heart disease. It's really important to establishing a baseline, looking at progression, assessing responses to treatment, and in particularly for us, making indications for surgery or intervention at the correct point in time. Their current practice, I think, is quite varied for everyone in the congenital heart disease world. We know the value of the good old eyeball. I've had a little look at that heart. It looks a little bit different from how I saw it last time, or maybe I look back over a few echoes and see things changing. We can use linear measurements such as M-mode, LVIDD, fractional shortening, or inverted commas volume measurements, which are based on multi-plane analysis and a bit of mathematical wizardry. And we can also use things like myocardial deformation imaging to gauge function. Problem with a lot of these approaches is, first of all, with the eyeball, you do have a subjective assessment and there's a lack of reproducibility there. A lot of the other measurements make huge geometric assumptions, either the single plane measurements or biplane measurements, they are just looking at a relatively small part of the heart and making calculations based on those areas. They are quite dependent on having complete echocardiographic windows. So particularly things like biplane Simpson's ejection fractions, very common that people don't quite get the apex into view, and that can completely throw off one measurement compared to another. For a lot of the systems, there's varies with the normal data, particularly with speckle tracking analysis, which can be vendor dependent, and we don't necessarily have that normal value for children. And all these carry large inter-observer and inter-study variability. And last of all, what about the right ventricle? I did like this quote from one of my colleagues that liked to think of themselves as being a holistic cardiologist because they treat both the ventricles. So the right ventricle in itself is an absolutely different problem compared to the left. It has a complex shape, unlike the left ventricle, which is essentially a cone shape. The RV has a triangular shape with no simple geometric calculations possible. And to make matters more complicated, the shape changes with different physiologies and different pathophysiologies. And there's no good way of getting a volumetric measurement on standard 2D echocardiography. So how do we muddle through at the moment? Well, we've got the good old TAPSE free wall tissue Doppler imaging. So we're looking at one tiny portion of the heart and making huge assumptions here about the overall global function of that heart. It doesn't represent the whole of the RV, and particularly in post-surgical patients, it's not uncommon that you can have adhesions of the tricuspid annulus to the anterior wall of the chest, meaning that the movement of the tricuspid annulus doesn't represent the overall function of the right ventricle. We then have fractional area change. So we're taking an apical four-chamber view. We're looking at, again, just a very tiny portion of the ventricle and making assumptions about the entirety of the ventricle based on that. Also, we know with that, depending on how the image is cut, depending on how good your observation of the endocardial border is, there's huge inter-observer variability. We now have pretty much a standard myocardial deformation imaging on the right ventricle, which looks at the septal wall, the free wall, but then we're not actually assessing the inferior and superior walls at all. We're not looking at the RV outflow tract, and it doesn't actually give us any measurements about chamber dilatation. And what everyone will always wheel out, the good old 4D echocardiogram, which the vendors are very good at bringing fantastic specimens into the demonstrations, young, fit, thin people who've got nice, small hearts. Unfortunately, the reality is that we're often dealing with people who it's hard to get adequate views on, let alone when the right ventricle is 2 or 3 times its size, trying to actually fit that whole right ventricle and get all of the walls and the valves clearly visualized on a single beat acquisition is extremely challenging. I've certainly never been very successful with that. The right ventricle is really important as it's often the most or sometimes the only chamber affected in congenital heart disease. In particular, conditions that we deal with every day, such as tetralogy of Fallot, patients with RV to PA conduits, univentricular right heart circulation, such as hypoplastic left heart syndrome, and patients with pulmonary hypertension. And what we know from multiple studies is that right ventricular function is an independent risk factor for survival. So accurate measurement of that allows us to time and intervene early enough that people are at less risk from their conditions. There are existing solutions. The gold standard currently is cardiac magnetic resonance imaging, which is fantastic for measuring left and right ventricular volumes. As the team has said before, there is limited availability of this, particularly in the UK and particularly for children. So frequent monitoring is not really very practical. Another huge issue in the congenital heart cohort, particularly with children, is that MRI is not necessarily tolerable for either younger children or people with neurodevelopmental disorders because the machine is noisy, it's claustrophobic. You need the person to be able to lie still, and preferably you need them to be able to comply, hold their breath, which for some people is just not practical. We also have patients who have contraindications, particularly in the post-surgical cohort, where they may have pacemakers, particularly with epicardial pacing wires, which can heat up in the CMR machine. So these patients can't go in the MRI scanner, or at the very least, if they can, the image quality is severely degraded. Then we also have a look at the cost of the scan. An MRI scan is considerably more costly and also carries around about 1,000 times the carbon footprint of an echocardiogram. So from a sustainability perspective, there are all issues there. As I mentioned before, we do have real-time 4D echocardiography, and it can provide a complete assessment without geometric assumptions by border tracking. However, it does require the acquisition of the whole of the ventricle from a single window, which is really challenging for patients with severe RV dilatation. It does not allow you to optimize the images at every single point on the right ventricle, and the resolution and border definition is poorer than on 2D echo. And as well, I think some of the algorithms that are used by the vendors don't take into account the various different pathophysiologies that you get with these dilated ventricles, and the accuracy of these is not very well established, and particularly the applicability for patients. It means that there's a significant number of patients where it's just simply not possible to get good enough views to make this viable. So this is where we come on to Ventripoint, which Jim outlined before. It's an adjunctive system used with standard 2D echocardiography. And what's really smart about it is it tracks the position of the probe in 3D space and then uses multiple acquisition windows, which means you can make each one of your echoes optimized for the structures that you're looking at, and then combine all of those optimized pictures together, mark out the anatomical points in the 3D space. So the only information going to the system is basically a cloud of 3D points with structures on them, and then it applies its knowledge-based algorithm, which has been trained on multiple hearts with different pathologies to give you an accurate 3D volume. So this is the system as you've seen before. And it really leverages the benefits of that 2D echocardiogram. Due to the better image quality, you have better temporal and spatial resolution, and the ability to see the whole of the right ventricle by just breaking it up into little chunks. Jim showed this picture before, but I think it's really informative here that you can see really the vast variety of different heart shapes that you can get with the different pathologies. And having a system that accounts for all of these when it's processing the data really helps you to get accurate information without needing to go into the MRI scanner. This is just a demonstration to show you on the very old system how it works. You can see this is the old magnet tracker, but I think you can see that it's the position sensing of the probe which allows us to get that three-dimensional information out of the 2D scan. Again, just showing you very briefly, this is my workflow. This is on the old system where we used to have these templates. So this is still available. If you prefer, you can drag the points over, you refine them, put them into the positions you like, and you do that across all these different windows that you've acquired. So I will not labor that one too long. Now, this is the newer system. So again, here, I've slightly accelerated this just so that you're not bored staring at pictures for a long time. But this is the new AI points detection system, which I think is absolutely a huge time saver, which goes from this being a specialist tool, which you can use on a few select patients in a specialist clinic environment, to really making this something which is deployable in an outpatient clinic for a much larger group of patients, because this is really, really time saving when you're doing a large number of patients. As you can see, we kind of go through all these windows in systole and diastole. Again, we can just refine those points. You do get your eye in very quickly with this. Having a starting point from the AI really helps. You just have a little bit of refinement there. Look at those edges. And usually it's just a little bit of nudging these points around to hit the edges of the myocardium as you see it. I like to play the images back and forth because that just helps your eye get into the movement of the various structures. And very quickly, you do build up this image. I'll just accelerate through this a little bit to get towards the end. So you can just see this happening on the source axis images. Again, I was trying to be as fair as possible here. So this is one I did just a couple of weeks ago, just to show you that this really only takes about 5 minutes of processing to get this point. And then there we go. This is just the last one. So then when you went through, you see this cloud of points. This is what the system bases the calculation of the volume on. The yellow area is the area that the volume that's been calculated tracks. And what's really surprising is that when you look at this, you frequently think, well, that's border tracking in action. The system does not actually see the images. All it sees are the points you put on. When you've refined that, you can sometimes find actually that the algorithm has kind of detected the borders in a better way than you have. And when you look at it critically, sometimes you find actually you're making adjustments based on what the algorithm has found, and you say, actually, no, I was wrong where I put that point first, and I can correct myself. Obviously, you always have to base the position of those points on the 2D images. But once you've done that, you can say, well, actually, that wasn't quite on, and you can have a look at it. Again, there's quite a few useful visualization tools here. These have actually been able to detect some regional motion abnormalities. So this is a patient with tetralogy fallow, and I think you can see a fairly nice demonstration of where the transannular patch was across the front of the RV outflow tract, which is this area where this is a area strain heat map. So this is showing areas that seem to contract and which don't contract. And again, I think that's quite a nice demonstration that you would expect in a patient with a transannular patch repair of tetralogy fallow to have an outflow tract that doesn't contract very much. This is just again to demonstrate, as Jim showed, this is the output report. We can do, I mean, as a standard, I will do both the left and the right ventricle. Again, for the patients with tetralogy fallow, one of the nice discoveries is that these patients can often be extremely challenging to do even fairly simple left ventricular volumetrics on, because the apex of the heart is rotated so far around that you are frequently finding the apex of the heart actually towards the axilla and even as far over as the scapula. That means that getting a good biplane image of the left ventricle can be extremely challenging. And I've found that using the Ventripoint to get the left ventricular data as well really enhances the accuracy. And as we know, one of the indications for pulmonary valve replacement in patients with tetralogy fallow is the development of left ventricular failure, or if you're starting to find that your left ventricular to right ventricular volume ratio is changing, that's another relative indication. So having accurate data for both the left and right ventricles is really important. So that shows you the system. When you actually look at the data, and this is the published data demonstrating the correlation between the measurements with cardiac MRI imaging. And you can see here, this is this shows the correlation of the end systolic volume between Ventripoint and cardiac MRI scan, and you can see that really excellent correlation. You can see here again, this is end systolic volume measured on a different study, which shows that really, really good correlation. And this is some data that we took after we introduced the system. So this is a bland Altman plot looking at ventricular size, and this is inter-observer variability between myself and one of my colleagues. And you can see there's really tight agreement between two people independently measuring these same studies. And this was prior to the introduction of the AI point placement, which I think will be a valuable tool for enhancing that inter-observer variability. When you see the data and you're confident that it is matching the 2D images well, there's a very, very high degree of confidence that what you're getting is good quality data that is applicable in clinical practice. And when we have had patients who have subsequently had cardiac MRI scans, we have found very, very close agreement between the measurements that we're getting between the echo and the Ventripoint. So this is our old Ventripoint system. So you can see how old this is. We've got our IE33 machine and this huge, enormous beast here, which really sat in outpatients, and it was extremely good for what it did. But this is when we got our new Ventripoint 3 system. Well, the console is the same, but we've now upgraded the software to version 4. This is myself and the team proudly standing around our lovely new shiny machine and looking forward to deploying it. And this is our lovely new Echo Lab, which we moved into with some really nice lighting and a lovely environment, and our lovely new E95 machines, which are fantastic. This is the Ventripoint machine deployed next to it. So again, this is it at home in the outpatient clinic where we're doing a lot of things. However, because of the small size of it, we can go into the wild, and I'm now dangerous, stalking the corridors of the hospital, carting around the Ventripoint machine along with an echo machine. And as you can see here, this is on a critical care unit where getting information on these babies is vital. So this is a patient who's on ECMO. We had some important questions to answer about the right ventricular volume. And even last week, I was asked to go and review a patient to check a borderline left ventricle. And I found that using the Ventripoint system allowed me to get really usable, accurate data in a ventilated baby that was really critical to their ongoing management. So just to go through a couple of case studies demonstrating the usefulness of the Ventripoint system, in particular the ability to do serial measurements of right ventricular volumes. The first case is just demonstrating a patient who demonstrates RV remodeling post-pulmonary valve replacement. So the first patient had tetralogy fallow that was repaired with a transannular patch at the age of 11 months. They had an MRI scan at the age of 12 years, which showed an end diastolic volume index of 129 mils per meter squared, end systolic volume index of 59 mils per meter squared. So both of those below threshold for intervention. At 14 years, they noted a deterioration in their exercise tolerance. They came in, and at that point, we had extremely limited access to cardiac MRI scanning. So we did a Ventripoint analysis which had shown a deterioration over that period of time with indexed end diastolic volume on the RV of 170 and end systolic volume of 92 mils per meter squared. So they subsequently went for a surgical pulmonary valve replacement. This is the serial data. So we can see at the start of the studies, the blue line is the end diastolic volume, the orange line is the end systolic volume. We can see that this is the initial VMS study prior to pulmonary valve replacement. The pulmonary valve replacement was done at this point on the timeline. And as you can see, as expected, we have quite a sudden drop in ventricular volumes. You can see that the stroke volume comes together, and we have an increasing stroke volume afterwards with an increasing ejection fraction over time. And at this point in time, we actually did a further MRI scan around 4 years post valve replacement. And the X's on here are the MRI scan values, which you can see correlate extremely closely to those on the Ventripoint. So this was once we had our MRI service back up and running again. So I think this is a nice demonstration showing that we've done serial monitoring of this patient. We've proven a sudden reduction in RV volume, followed by an increase in RV function, which has been sustained over the long term. We can monitor this patient very confidently now over a longer period of time. The next patient is someone who sadly demonstrates adverse remodeling following pulmonary valve replacement. Again, initially, this is quite a similar story. This is a patient with tetralogy fallow, which was repaired with a transannular patch at the age of 9 months old. They had an MRI scan at 9 years old with an indexed end diastolic volume of 144 mils per meter squared, end systolic volume index of 85 mils per meter squared, which in itself is a relative indication. However, at this age, I think indexing to body surface area has its caveats due to somatic growth. They had a cardiopulmonary exercise test at the age of 13, showing a really quite diminished VO2 max of 52% predicted, with an oxygen pulse of 57% predicted, indicating that their effective stroke volume is very much blunted, which is what we expect with severe pulmonary regurgitation. We did their VMS assessment at 13 years, and we got relatively modest dilatation here. However, based on symptoms and cardiopulmonary exercise tests, they underwent a pulmonary valve replacement at 14 years. Once again, we see here the values prior to surgery. This is following the surgery. And I think whatever was going on, they had progressive fibrosis of the right ventricle, which was long-standing. And you can actually see that their volumes increased. At this point, we did an MRI scan, again, to concur with the Ventripoint assessment that demonstrates, again, very close correlation between the figures that we got on MRI versus VMS, which did come down. Again, I think this is probably reflecting the pubertal growth spurt finishing, which means that your body surface area increases whilst your heart stays the same size. But what we see here is a patient who on serial monitoring demonstrates that adverse remodeling. Again, I think this is just a nice demonstration of how you can apply that serial monitoring approach to younger children. One of the areas I'm quite interested in is that we have not been monitoring these children at younger ages when we've not had access to MRI scan. And we now have some more of this data, which we can use to try and predict when the timing is right for pulmonary valve replacement. Again, I have a few of the references here, which we took information from before. If people are interested in looking at those, I'll put these up so we can maybe catch them in the video later on. There we go. I think we're time for any questions. Does it matter, or is there further someone to talk?
Yes, thank you, Dr. Skinner. It's really powerful there to see the data points there showing the serial monitoring over time. To your point, yes, we do have sort of 5 minutes. We've run quite long there looking through the clinical studies there for further questions. So we'll open the floor to the audience now. So if you have any further questions, please type them into the Q&A box. We'll answer as many as we can in the time we've got left. So if you've got anything, any questions about the case studies or clinical use, please address them to Dr. Skinner. And if it's about the technology or the marketing, then we can obviously put them to Jim and Joe respectively. Thank you. Okay, so Jim, we've got one here about the reproducibility. So we saw some data there in Dr. Skinner's presentation about the interoperator reproducibility. Do you want to talk to the audience about how Ventripoint overcomes overcomes these limitations?
Well, our data sets that we acquired when we were doing our formative testing showed that we were always in pretty good agreement with respect to the MRI data and the Ventripoint volumetric data. As long as you're doing your best to achieve your good echo image, our system is pretty forgiving in such that it can accommodate to that to the volumes that are being required at that time.
Okay, thank you. And Dr. Skinner, you showed your paper showing or an internal paper there. You showed the results from your team. Were there any sort of call out points that you would like to highlight?
No, I mean, I think we were pleasantly surprised about how close that was. We were, again, we did that as a poster presentation at one of the British Congenital Cardiac Association meetings and published it there. I think we were very strict with ourselves that we just basically brought the study up. We had no contact with each other, just independently did it and put the numbers in. So we found that very close correlation. I think that that was on the version 1 system that didn't even have that template function of pulling the template over, and we were literally just putting points on. So I do think that you probably will get more consistent data with the AI point placement, because I think it just gives you that slightly more refined initial positioning, which is going to help with that as well.
Okay, great.
Dr. Skinner, we have a question here from our attendees. I had mentioned about not needing to have perfect images. You had mentioned the idea that 3D echo, 4D, live 4D, whatever you want to call it, sometimes does require perfect windows. They're asking what your clinical practice has been for that.
For
suboptimal images and using the 2D.
Yeah, I mean, one of the useful things is that you get multiple bites of the cherry for the image acquisition. So if you've got a slightly suboptimal window, what you basically need to do is you need to see the specific structures that you want. So you're marking off the tricuspid valve, you're marking off the pulmonary valve, you're marking off the anterior wall, the septum, the inferior wall. So because you're taking images from so many different windows, you optimize the view from a different window for a different structure. The difference between that and 4D echo is that you have to get all that information. So we know that if you're taking an apical image, your images of the pulmonary valve are really, really difficult to get on that apical image. Whereas if you're coming up onto a parasternal view optimized for the pulmonary valve, you can see that. Obviously, if a patient's got no windows, you cannot do the study. However, it's surprising how much you can get away with by just saying, okay, all I need to see are these specific structures, focusing in on that, and the rest of the image quality doesn't need to be quite as good as it does for other analysis.
And because of that higher 2D echo quality rather than the extrapolation that 3D does. And then the final question we had, and this may be for you, Jim, how well does it work with 3D echo? Would this be getting more into our workstation if they wanted to export data? And maybe it's one we could put as an offline answer.
It works well with 3D echo. I mean, if you can acquire a good volume data set of the RV and you can see pulmonary and you can see tricuspid, and you can see that all in that 3D echo acquisition data set, then we're good to go.
Okay. And then their question was, would that make it faster than perhaps 2D? And we probably should have mentioned, Jim, would you say this is adding 5 to 10 minutes? I mean, it depends on how many chambers they're measuring, but 5 to 10 minutes to a study?
5 to 7 minutes. Once you acquire this, the imaging session is the imaging session. That's already accounted for time. It's the extra little analysis. Our AI helps speed that through. From that standpoint, from a 3D standpoint, that's a little bit more tricky. It's just the way that all the different planes that are required from a 3D acquisition standpoint require a little teasing out to find the views from within that big, huge Siemens or Philips or GE volumes. Yeah.
So we could actually be quicker on the 2D and standard 2D images like we were talking about.
Certainly.
Okay.
Yeah. What I'll do, Joe, I know Dr. Lars has done 2 papers on VMS using 3D echo, so we'll put those on the list afterwards. So if people want to follow up, then they can see the papers published in that area.
And then we have another question about smaller children, and perhaps them moving around.
Shall I ask this one?
Yeah, the clinical makes the most sense.
Yeah.
Not that you're not, Jim.
Yeah. No. It's not going to give you good results with a screaming toddler, I'm afraid, though very, very few things do. I think the patient needs to be relatively still. I mean, the perfect patient is someone who's lying still, who is able to perform breath holds, because similarly with MRI scan, the heart is moving within the chest when you're taking breaths. My practice is probably over the age of about 4, or small babies who are on the intensive care unit, particularly if they're sedated and or paralyzed. They're very, very easy to get good images from and to get that good data. For the younger kids, I've actually found if you try and get them to breath hold, they start doing funny things with their breathing, and it's actually much easier to just say, you just go there and you time it. I think that the software is able to compensate for that to a degree. So what you'll find is maybe the overlay of that yellow 3D image doesn't exactly register on the model exactly where it is, but actually if you look at the size of it, it's the right size. And I think that's because you've got that little bit of respiratory motion that's going on. So probably you're not quite as confident in those numbers, but you have to take that into account. But again, what you're doing is you're measuring things in a serial manner. And on those children, when I measure them serially, I'm getting very, very close data on multiple acquisition.
Right.
Great. I think we've got
PICU, like you mentioned. I'm sorry, Matt.
That's okay. No, I think we've got time for one question here. We've slightly overrun there. So you covered it partially in your presentation earlier, Jim. But could you just explain what the purpose is of the 2 sensors that are used? So the one on the patient and the one on the patient. Oh, sorry, one on the probe. Forgive me.
So those sensors allow us to acquire position information of the transducer in that space over the precordium. And so as Greg showed that dye moving in the window, what we're what we are acquiring is the position of the transducer, which is essentially the position of that cine in that orientation of that plane that was being acquired. So when you're in your 4-chamber and you counter rotate 90 degrees to the 2-chamber, when I'm speaking for the LV, we understand how the 2-chamber of the LV interrelates to the 4-chamber of the LV, and then on top of on top of the precordium instead of the apex, we can see how that position information interrelates to the apical window. So that's what the sensor technology is providing us.
Fantastic. I'm afraid we're going to have to hold it there this afternoon. We're right out of time. So this brings us to the end of the time. So I'd want to thank Dr. Skinner for sharing his clinical insights today, and for Joe and for Jim for sharing their market and technical content. For the questions that we didn't get to answer today, we'll collate them and put them in the email, which we'll send to you all tomorrow with the links of today's presentation and the case study as well. On the screen there, we've got some QR codes that you're welcome to clip. So one will request the white paper from the Ventripoint website. The second one there is the demo request, and the third one is our LinkedIn. So if you'd like to request a demonstration, please email Joe on the address given here on the screen, or click or use your QR code on the demo request, which will take you through to our website. Finally, thanks for joining us today. We'd really appreciate your feedback, and we'll send you a questionnaire within the next 24 hours to collect feedback on how you found today's presentation, and also collect any other subjects that we could bring to you in one of these webinars at a future date. So thank you for joining us today and for the work that you do with your CHD patients every day. Have a wonderful rest of your day, and thank you again for joining us. Thank you. Goodbye.